Big news! Multiple generic entries for Farxiga, dapagliflozin, are expected this April before others in the class. Another reason to prescribe Farxiga today. View efficacy and safety information at farxiga-hcp.com.
Farxiga.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, CardioNerds. I'm Shazli Khan, co-chair of the Advanced Therapy series. In our last episode, we were joined by Dr. Kelly Schlendorf and discussed all of the steps involved in the pre-transplant evaluation. If you haven't already, be sure to check that out. In today's episode, we move along in our advanced therapies journey in which we will be discussing the perioperative management of transplant, including the crucial steps going into the OR, being in the surgery, and coming out of surgery safely. We're again joined by Dr. Jenna Skowronski, chair of the CardioNerds Heart Failure Council and current UNC director of Cardio OB.
Thanks so much, Shazli. I'm thrilled to be here. I'm going to introduce Dr. Natalie Tapaskar. She's an advanced heart failure and transplant cardiologist at UT Southwestern Medical Center in Dallas. She completed her internal medicine residency at University of Chicago and then general cardiology and advanced heart failure and transplant fellowships at Stanford University. She graduated in 2024 and joined faculty at UT Southwestern. She practices advanced heart failure and transplant cardiology and is also the medical director of the HCM program. Natalie, thank you so much for joining us. We're thrilled you're here.
Thank you so much, Jenna. I'm really excited to be here. And I'm excited to welcome Dr. Jason Katz, who is Associate Chief of Cardiology and Director of Inpatient Cardiology at Bellevue, as well as Program Director for the Advanced Heart Failure and Transplant Cardiology Fellowship at NYU Langone and editor of JCF Intersections. He's a national leader in advanced heart failure, mechanical circulatory support, and transplant cardiology. He has a passion for improving care for critically ill cardiac patients and those supported by mechanical devices. Dr. Katz, thank you so much for joining us.
Thanks for having me. Excited to be here.
All right, we also have Dr. David Kaczorowski joining us today, Surgical Director of the Advanced Heart Failure Center at UPMC. He's a national leader in single and combined organ cardiothoracic transplant, mechanical circulatory support, and ventricular assist devices. He's helping push forward the field towards DCD and xenotransplantation research. Dr. Kaczorowski, thank you so much for joining us today. We're so grateful to have your surgical perspective.
Absolutely thrilled to be here. Thanks so much for having me.
We're going to get started with a pretty long case from the CardioNerds ward, so bear with me. Mr. Perry Chop is a 65-year-old Caucasian male with a history of type 2 diabetes with an A1C of 7. He has ischemic cardiomyopathy for the past 20 years. He had initially presented to cardiac care in his mid-40s with dyspnea and chest pain and was found to have an NSTEMI and underwent PCI to his LAD, with a recurrent LAD PCI a few years later for in-stent restenosis. His LV systolic function has been 15 to 20% for many years, despite being on all pillars of guideline-directed medical therapy. His latest echocardiogram demonstrates an LV internal diastolic dimension of 7 centimeters, moderate RV dysfunction, and mild to moderate mitral regurgitation. Up until last year, he had largely remained functional without any heart failure hospitalizations. However, in the past year, he has had progressive functional decline, progressive hypotension necessitating withdrawal of his beta blockers, and dose reduction of his RAS inhibition. A cardiopulmonary exercise test was done as an outpatient, which showed a peak VO2 of 8.4, which was 31% predicted for his age, with a VE over VCO2 slope of 64. A right heart cath demonstrated an elevated right atrial pressure of 14 millimeters of mercury, PA pressures of 43 over 24 with a mean PA pressure of 31, a wedge pressure of 26 with V waves to 35, and a cardiac index of 1.63 to 1.59 by Fick and thermodilution, with a PVR of 1.42. Given these hemodynamics, an expedited heart transplant evaluation was initiated, and he was started on inotrope therapy with milrinone. But he's had persistently poor hemodynamics, requiring insertion of an intra-aortic balloon pump, and was ultimately listed status 2 for heart transplant. His renal function is mildly abnormal with a GFR in the low 50s. He is a blood type A, 6 feet tall, 90 kilograms, and not sensitized with a CPRA of 0.0. He's had no prior cardiac surgeries and no malignancy or infection history. So that's a long history. But Dr. Katz, as we think about the basics of donor heart selection for this patient and for others, we know that the first successful heart transplant was in the 1960s, but we've had a significant gap between available organs and the number of patients who could benefit from this life-saving therapy. There are a few main categories that come to the top of our minds when we evaluate donors, such as age, sex, size, metrics of LV function. For Mr. Perry Chop, could you walk us through your thought process about how you would approach donor selection for him and where you would land on the spectrum of extended criteria or high risk versus standard risk versus low risk donors and what all of that means to you?
Awesome. You have a few hours. That's a lot to unpack, Natalie, but I think let's try to go through this systematically here. And lots of great questions. Like I said, we could probably talk about this for quite some time, but I think it's important that we begin with a few probably critical acknowledgments. First, donor selection or matching patients with donors. It's, in my experience, a very inexact science. In a lot of ways, it's an evolving science mixed with the art of medicine and plenty of clinical gestalt and sprinkled with a little luck as well. We do our best when vetting these potential donor organs to find just the right organ for the right patient, but there are lots of confounding factors and variables that are really impossible to overlook. Among these are the age of the patient, the severity of illness, probably more specifically the trajectory of the patient and their illness severity, the complications and comorbidities, which they're actively dealing with, and then things like regional organ availability and others. And then we should also acknowledge for the learners and young faculty that are listening to this podcast, taking donor call can be pretty stressful. In many cases, your decision leads to a domino of events, processes, including waking up your surgeon sometimes in the middle of the night. And these things are resource intensive and costly and quite impactful, obviously, to patient outcomes. And again, many of these calls don't happen in the middle of the day, but rather the middle of the night or early morning hours when you might not be thinking the most clearly. And you may be just kind of arising from a deep slumber, but they're tough decisions to make. And this is an area of transplant cardiology that I think requires a lot of mentorship. And in fact, as a program director for Advanced Heart Failure and Transplant Cardiology Fellowship, I think the potential fellows know about this too, because almost every interview day, I have a number of people ask about how they're going to learn to take a donor call in the middle of the night. And so I think these things are on their mind, and they're certainly on my mind as a program director, and they require mentorship and partnership. And it's a skill set that I think takes time to cultivate. And to be completely transparent and fair, before I get even a little further into Mr. Perry Chop, I used to take donor call all the time. I'm at a place now at NYU where I no longer take donor call, and I'm not particularly mad about that because, again, how time consuming and challenging and stressful it can be. And I just feel lucky to have partners within our organization that have helped to sort of lead the efforts at NYU and streamline a lot of that. So I just wanted to get that out there first for particularly the learners on the call. But I think there are a few things that we know or know reasonably well about Mr. Perry Chop, who you just described. He's an older gentleman, nearing the upper limit for recipient at many institutions. In some ways, that may impact the timeliness of his transplant. He's also ill, needing a balloon pump or hemodynamic support. His listing status is probably status 2, suggesting again that there is some urgency in his transplantation. His end organ function sounds reasonably stable. He's not tragically sensitized like some of our patients may be. So it gives us a little bit of wiggle room. I'll emphasize that there are donor heart selection guidelines that were published in JHLT in 2022, and that's a good, useful guide for reference. So I think number one, we know that donor age is a risk factor for many post-transplant outcomes and complications, and many institutions won't accept a heart from a donor over the age of about 60 or so. Most try to keep it in the sort of less than 40 or less than 45 age range. And if they're willing to accept an older donor, most would suggest screening those older donors for coronary disease, keeping ischemic times as short as humanly possible. And so I'd want to get as young a donor organ for Mr. Chop as possible. If he was more highly sensitized, I might even be willing to accept an older donor, given the smaller potential compatible donor pool. But for him, I'd like a young donor. There are no really standardized, and I've looked into this my whole career, standardized sort of sizing metric to think about, but most use a predicted heart mass as the preferred tool. And we're much more willing to, I think, oversize a heart than actually undersize a heart, especially in a patient that has other comorbidities or risk factors like pulmonary hypertension, or if it's from an older donor. And most recommend a predicted heart mass within about 20 to 30% of the recipient. We historically, in my experience, have avoided female to male donations, but still reasonable depending on how quickly you need a heart, particularly if the predicted heart mass is reasonably close. There are lots of online calculators people use to calculate this and compare predicted heart sizes that can be useful, particularly for the young faculty member taking donor call. And then every donor heart is screened with an echo. When LV dysfunction is present, we consider these hearts for extended criteria. The idea is that we might utilize these donor hearts with the goal of expanding use while still mitigating recipient risk. Hearts may also initially have a lower ejection fraction depending upon mechanism of injury or death of the donor. especially in young donors. So serial echocardiography can be really helpful to assess the potential donor organ. And it's reasonable even to consider a heart with a reduced but improving ejection fraction in high-risk patients. And these are just some of the factors. There's lots that we could talk about. As I said, we could talk probably for hours about this one initial question, but those are some of the things I think about right away. Other things are like the presence or absence of significant valvular disease, coronary anomalies, concomitant infections, how the patient died, the mechanism of death, and the metabolic state of the donor, the need for other therapies to support the heart. But that's kind of what I think about from the very beginning. I hope that was a good starting answer to your question.
That was fantastic. Thank you. I've also realized there's a lot of variability between institutions about whether surgeons or cardiologists take donor call and make decisions about organs. Dr. Kaczorowski, I was wondering, just from your perspective, additional things you might consider. I'm on donor call as we speak, and I will immediately just get on a conference call with my surgeon, who I love dearly. So I would just love to hear your perspective on how this is kind of a group decision between the surgeon and the cardiologist.
Yeah, I think first off, I agree with all those points. It's a complex decision. When you're assessing these situations, you're thinking about not only the donor, but also the recipient and how they're going to work together. And I think when you have a really complex recipient, and what I mean by that is perhaps a recipient with a very complex surgical history, that's one thing to take into consideration. Then I think, as you pointed out, the recipient's age. And really, when I'm thinking about age, I'm thinking about their ability to tolerate some physiologic stress, like how much graft dysfunction can this recipient tolerate? If it's not very much, so if you have an older recipient that perhaps has some renal insufficiency, I think they're going to tolerate less graft dysfunction without getting into trouble. So in those cases, I'm going to be a little bit more cautious with the donor selection in general. When I say cautious, I mean less likely to undersize the donor, less likely to go further away. We talked about age, size, and of course, metrics of function. But I think you also have to consider distance as another important parameter, in addition to all the other things that you outlined about the donor history. So again, when you have someone that's not going to tolerate a physiologic stress, I think you have to be a bit more cautious with the donor selection. If you have a patient that's very surgically complex, like someone that's already had 4 sternotomies and also needs a liver transplant, that's probably not the time to use a 55-year-old heart with a low ejection fraction. So I think that's sort of how I think about it. It is good to have multidisciplinary discussions about each of these patients. At UPMC, we split the donor screening. Myself and the surgical team does a lot of it. If we have an offer that we think is good for a particular recipient, we'll generally talk to the heart failure cardiologist on call or the heart failure cardiologist that knows that patient, discuss the offer with them, review it with them. They may also review the echo, the cath if it's available, and we make a decision together about whether we think that's a good heart. If the recipient's sensitized, we also involve our HLA lab. We may have a multidisciplinary discussion about whether this is a good offer. Oftentimes, if they're very highly sensitized, they may not be perfect from an immunologic standpoint, but if they're very sensitized, you may not be able to do much better. So that becomes an important consideration as well in some cases. So we do try to tackle this, as I said, from a multidisciplinary standpoint, and I think that's beneficial to the patients as well.
Thank you so much. That's really helpful. I think as we think about optimal donor selection for our patient, Mr. Perry Chop, which I love his name, Natalie. Thank you for coming up with that. I think that it's really important, and it wouldn't be a complete discussion without talking about the differences between DBD or DCD. So donation after brain death, for those of you guys listening that don't think about this every day like we do, or donation after circulatory death. And we've touched on this just briefly in some other episodes. The first successful heart transplant, as Natalie had mentioned, was in 1967, and that was actually a DCD donor. But it fell out of favor for many years as donation after brain death became kind of the standard. And now in the United States, donation after circulatory death is one of the 2 things, I think, in addition to Hep C organs, that has really helped to broaden the pool of potential organ donors that we're able to consider. So there continue to be ethical debates around the procurement strategies and kind of the lack of data on very long-term outcome for DCD, although the 1 to 5 year outcomes seem promising and similar to that for DBD. So Dr. Kaczorowski, can you just highlight basic differences between DCD and DBD, and then just focus a little bit on defining ischemic time between the 2, maybe differences in procurement strategies, thinking about normothermic regional perfusion and direct procurement and perfusion, and then I guess a little on long-term outcomes. And this is just a final question. I'm sorry, it's a lot. But do you change your donor selection criteria at all whenever considering a DCD donor? Or are there patients, are there recipients that you wouldn't be willing to accept DCD for?
Yeah, absolutely. Thank you. These are really good questions. To start, the differences between DBD and DCD donors start with really the very nature of these donors and the definitions of each of these types of donors. As you pointed out, DBD stands for donation after brain death. So the donor has already been declared brain dead, and the heart and the organs can be procured directly, then preserved, transported, and then transplanted into the recipient. In contrast to that, DCD stands for donation after circulatory death. So in this situation, the donor has usually suffered some serious form of a brain injury or has some sort of a life-threatening or life-limiting condition, and the donor's family has made the decision to withdraw their life-sustaining support. After the support is withdrawn, the donor passes and is declared dead. There's a mandatory standoff period, and then the organs can be preserved. So they're very different, and those are some of the differences. When we're talking about procurement strategies, there are two different techniques that can be applied. One is called direct perfusion, and the other one is called normothermic regional perfusion, and these can be applied to DCD donors. Direct procurement is conceptually the most straightforward. Basically, after the donor is pronounced dead and the standoff period is elapsed, a sternotomy is performed, the aorta is clamped, cardioplegia is administered, and then the heart is directly procured. The heart's usually placed on a perfusion circuit and can be reanimated and assessed on the circuit. NRP is quite different. In this technique, again, the life-sustaining support is withdrawn from the donor is pronounced, the standoff period elapsed. In this case, a sternotomy is performed and the aorta is essentially clamped so that the cerebral vessels are not perfused. And basically, the donor is put on either ECMO or some form of cardiopulmonary bypass, and the organs, but not the brain, are resuscitated. After the organs are reperfused, a period of time elapses while blood perfuses these organs, and then the heart and the other organs can be assessed, procured, preserved, transported, and then transplanted. Now, because of these differences in the way these organs are managed between DBD and DCD, the definitions for ischemic times can be a little different. And I think it becomes actually a little bit confusing. And in some cases, it's easier just to think of it as out-of-body time. But regarding ischemic times, for DBD donors, it's fairly simple. The total ischemic time is simply the duration of time from the time that the aortic cross clamp is placed on the donor aorta and cardioplegia is delivered, and the heart is then removed, and then it's taken to the recipient site, sewn in, the cross clamp is removed. That's the ischemic period, from the time that the heart undergoes clamping at the donor site to the time the clamp comes off at the recipient site. That period of time, the total ischemic time, can be further broken down into warm and cold ischemic periods. The cold ischemic period is the period of time from when the aortic cross clamp is placed in the donor, the heart is flushed and placed on ice. That's the cold ischemic period, essentially. When the heart arrives at the donor center and the heart's removed from its packaging and sewn into the recipient, that's considered warm ischemic time. So those are basically what we consider ischemic times for DBD donors. For DCD donors, it's a little more complex. In DCD donors, as we discussed, the life-sustaining support is withdrawn. There's usually a period of time where the donor is hypoperfused prior to the heart stopping. We'll generally refer to this as a warm ischemic period or a functional warm ischemic period. The heart then stops. Then again, either direct procurement or NRP is performed. And then the heart is procured and then transported to the donor site. And as I said, it may be placed on a perfusion circuit, which further complicates that definition. So it can be a little bit more confusing for DCD donation. And I think those definitions are evolving, and the significance of these periods really requires further study. You had asked also about long-term outcomes. I think data is emerging on this topic as well. What we know about early perioperative outcomes between DBD and DCD donors is that they're fairly similar when it comes to recipient survival. Our group has looked at this in a variety of ways, including the use of the UNOS database. What we and others have also found, again, is that when DCD donors are used, perioperative outcomes are very similar. When your recipient survival, that is very similar. We know that the use of DCD donors can also shorten waitlist times for recipients as well. Data is emerging on longer-term outcomes with DCD donors, and those data look very promising and suggest that DCD donors result in similar long-term survival. One area where I think there is some difference, there has been in both randomized trials looking at direct procurement, and from some UNOS data, there is a suggestion that there is a higher rate of primary graft dysfunction with DCD donors. And I think that actually may influence the way we think about the use of these donors for some recipients. So I think your final question was about how we change donor recipient selection when considering DCD. Well, I think DCD hearts can shorten waitlist times, can result in similar recipient outcomes. So we view them as a way to expand the number of donors available for our recipients. But I think we are a little cautious again when we have a very complex recipient about the use of DCD donors, because as I said, I think the data is demonstrating that there is a somewhat higher incidence of primary graft dysfunction. So in a recipient that will not tolerate that from a physiologic standpoint, we're cautious about the use of DCD donors. But I would say that most of our patients are listed for both DBD and DCD.
Thank you. That was super helpful. You've made a fairly complex topic pretty understandable for us, especially for me as an advanced heart failure fellow. So thank you. But, as you alluded to, this is not the simplest topic to understand. And so I just was wondering, Dr. Katz, as we increasingly utilize DCD donors, we are cognizant of counseling our patients effectively on what to expect with a potential DCD donor. I know different centers probably differ in how they explain the DCD heart transplant process to recipients and the possibility of a case even being canceled. So can you share a little bit about how you tend to approach this conversation with your patient?
Thanks. That's a great question. First of all, I'm so glad you gave the last question to Dave. He did such an expert job of responding to that question in such a thoughtful way. I thought you were going to ask me for any additional information. I was going to say I have nothing at all intelligent to add to what he said. So thank you for sparing me this. I mean, this is a great topic. I find it really interesting. It's certainly an evolving field. Clinically, it's evolving. Ethically, it's evolving. There are a lot of personal nuances to be sure. And you said this before, and I'll reiterate it again. DCD donation is exciting. It really does have the unique potential to greatly increase the donor pool and reduce waitlist times and at least waitlist deaths. But there's certainly a lot to learn. The short-term outcomes, as Dave mentioned, have been pretty comparable to DBD donation, but we don't know that much still about the longer-term events. And I think it's important to be transparent and honest in our communications with the patients and their families. I've always tried to do this throughout my career, and this particular topic is no different, to emphasize what I know or what we as a field know, and to be transparent and honest about what we don't know yet, particularly about longer-term DCD outcomes. And I tried to explain in layman's terms, if possible, the differences DBD versus DCD transplantation and the procurement process. I sort of try to gauge how much the patient and family really wants to know about that. Some want to know all about it. Some have Googled it before I've gotten in the room, and some really don't have that much of an interest. They just want a heart and whatever will get it faster. And they put their trust and faith, particularly in the surgeons, to do the job. But I'm willing to sit with them and discuss this as much as possible. I am not an artist. I have daughters who are very artistic, but I still will try to draw pictures or use graphics where I can, because I think that can be helpful to sort of differentiate the two, particularly for families that are trying to understand the difference when we're consenting them for possible DCD versus DBD. I try to be sort of simplistic about it, or as sort of simple as I can be, but complete still in the explanation of, in particularly concepts around direct procurement and perfusion versus normothermic regional perfusion techniques as well. And to your point about the possibility of a case being canceled, I try really hard to explain to the patients and families that no matter the type of donation, this is a possibility. We vet the organs best we can, but I always admit to them that there's a possibility that our surgical team arrives at the site and rigorously examines the organ in real time right in front of them. No matter how much we vet the patient or the donor or the organ ahead of time, nothing beats that direct visualization by the procurement team. And if the case gets canceled, then it wasn't the right heart for the patient. And I emphasize to them, especially like they have a bad heart. They don't need another bad heart. We want to get them the best heart. And if we make a decision that it's just not the right heart for organ status reasons, then that's the reason. And again, like I said, I try to go through the whole sort of DCD process and how that might be canceled as well. And I let them ask as many questions as possible. I think that's really important.
Thank you so much, Dr. Katz, for that wonderful answer. I think it's very evident so far that both you and Dr. Kaczorowski have a lot of passion for this field, and we really appreciate all of your insights. And that leads us to my next question. When DCD cases get canceled, that's hard for both the provider and the patient. And as a heart failure cardiologist, it's not something we think about regularly, about the exact nuances of what happens when the surgeons go to procure the organ. And in 2020, the ISHLT published a consensus statement on donor heart and lung procurement. And in the document, they mention a few interesting things. Milky fluid that may be seen in the pericardium of a brain-dead donor, or mediastinal hematomas from chest compressions that may raise the possibility of myocardial contusions, things that cardiologists might not think about. And so that leads to the next question for Dr. Kaczorowski. Could you walk us through how do you generally inspect the potential donor heart when you're procuring? And then what are some features that would make you turn down the organ? And then are there any key steps during the whole procurement or transport process that you think are particularly critical for the organ health?
Yeah, for sure. Thank you for that question. Well, I think when you're assessing a donor heart, it starts before you ever leave. You have to consider all the things that we talked about and make good decisions about the donor heart, the donor age, the sizing of the donor heart, the distance between the donor and recipient hospitals. What's the ischemic time going to be? Long time ago, we couldn't see the echoes or caths or anything unless we traveled to the donor site. Now, obviously, we can see all those things electronically, and we have a fair amount of history. So I think we can really get a pretty good idea if this is going to be a good heart for our patient before we ever leave. And that's a good thing because obviously we know that transplantation is expensive and it involves a lot of expensive things, but certainly the travel that is required is among them. So I think carefully evaluating those things before ever accepting a heart or traveling to the donor site makes a lot of sense. Once you get there and the donor's in the operating room, the sternotomies have been performed, there are a number of things to really look at. Obviously, assuming it's a brain dead donor or if it's an NRP case, you certainly want to look at the function of the heart. It's really hard with your eyes to look and see what the LV is doing, but you can get a really good look at the RV, particularly for experienced heart surgeons that have looked at a lot of hearts and come off bypass with a lot of hearts. You can really get a sense of what the RV is doing just by looking at it. You can look at the RA and get a sense of how full it is. And that really gives you a good idea of what the function of the heart's going to be like. Certainly, if there are any questions, you can get a T in the operating room if it's available. You also want to look at the heart and look for evidence of any coronary disease, and that might be something that would cause you to turn down an organ. For example, if the donor did not have a catheterization prior to the procedure, you get there, you palpate the coronaries, or simply look at the coronaries and observe some coronary disease. That's certainly something that would make you turn it down, in addition to poor function. You want to look out for any arrhythmias. Some of them can be very benign, like AFib. It's not uncommon that you manipulate a heart and actually put it into AFib, but certainly if they're having VT or anything like that, that's a concerning feature. Along those lines, you can look for any sort of scarring or anything like that in the myocardium that might suggest that the patient's had a prior infarct. But again, a lot of the information that you really want in terms of the echo, the cath, and the donor history should be available before you even get there. In terms of key steps during the procurement or transport process, primary graft dysfunction is a big problem, and you really want to do everything you can to avoid it. So in addition to making good decisions about donors in general, it's really important to protect the heart. And what do I mean by that? Well, from a technical standpoint, there are some very important things. You want to make sure that the heart is decompressed at all times. You don't want the heart to become distended. You want to make sure that there's adequate cardioplegia delivery. You want to make sure that the aortic cross clamp is placed all the way across the aorta and that there's good separation from the heart, the rest of the circulation while the cardioplegia has been delivered. And then obviously when you're cutting out the heart, you want to avoid injury to the important structures. Those things are all conceptually straightforward, but it can be a very chaotic situation when these organs are being procured in the middle of the night and there are teams competing for space and the situation is rushed. So all those things I think are very important to keep in mind for donor teams as they're procuring organs. And then again, the process of storing and transporting the organ is very important. For many years, cold ice has been used to preserve organs while they've been transported to different locations. I think data is emerging to suggest maybe that's not really the best way to do it. And so we have a number of strategies that are emerging that may be better than simply using ice. That is just essentially standard cold storage at a temperature between 8 and 10 degrees, and then a variety of different perfusion circuits, which may allow reanimation of the heart and assessment of the heart, or simply perfusion of the heart at a cooler temperature. So I think all these things are evolving, and I'm really looking forward to seeing how data develops on each of these preservation strategies, because again, I think primary graft dysfunction is still a major problem in the field. It's not common, but when it does occur, it has a major impact on the patient. We need to figure out how we can avoid that essentially 100% of the time. And I think some of these new preservation strategies will help us to do that.
That's so helpful. Thank you. That was one of my favorite parts of my transplant year when I was at Vanderbilt, was just getting to hang out with the surgeons and hear about all the really amazing things that they were doing. I'm curious, do you all try to avoid amiodarone in the recipient prior with the data on like amio maybe being related to primary graft dysfunction or no? That was always something we've discussed, and I had all my patients on amio all the time.
I think generally we try to. Whether we can do that 100% of the time is less likely.
Yeah, I think less likely feels like the right answer. Okay, so we can go back to our patient, Mr. Perry Chop. So after 8 days at status 2, an optimal donor was found for the patient. He receives a heart from a 22-year-old male DCD donor who was 70 kilograms and 6 feet tall, giving him a predicted heart mass of 0.91. Procurement was via direct procurement and perfusion, DPP, with recovery support on the organ care system, OCS. Total donor ischemic time was 330 minutes, and he returned to the ICU post-operatively. Sorry, Dr. Kaczorowski, we're just skipping the whole OR part. After a fabulous surgery, he returned to the ICU post-operatively on the following vasoactive agents: dobutamine 5 micrograms per kilogram per minute, epinephrine 0.05 micrograms per kilogram per minute, and inhaled nitric oxide at 20 parts per million with his intra-aortic balloon pump still in place at 1 to 2, which was subsequently removed in the ICU. He had epicardial wires set to an atrial pacing at a rate of 110. Dr. Katz, can you walk us through the typical vasoactive agents that patients will leave the operating room on, thinking just immediately after heart transplant, and kind of metrics that you utilize to guide wean?
Okay, awesome. I'm not sure there are typical vasoactive medications, and I find that there's a sort of a culture and a therapeutic model that's often employed at different institutions and by different surgeons and anesthesiologists. And I've learned to adapt over my career. And if you're looking for hardcore randomized controlled data to sort of guide your vasoactive choice in the early perioperative and postoperative setting, good luck. Tell me when you find it. So this is kind of a loaded question, but I love this. I mean, I spent most of my career as a critical care cardiologist actually operating in the postoperative cardiothoracic surgical ICU. And I love it for a lot of different reasons, and a different type of critical care medicine than it is in the preoperative cardiac intensive care unit. So I love the partnership. I've worked in partnership with cardiac anesthesiologists and cardiac surgeons my entire career. And that partnership has been critical, pardon the pun, to my work in the intensive care setting. And what I've learned over all these years, again, is that there really isn't anything that's particularly typical for vasoactive medications. And what happens in the operating room, especially if you're not there, and I'm usually off drinking a cup of coffee while our surgeons work hard in the operating room for several hours, that's part of the fun and part of the mystery in my mind. And I've had patients return to the ICU with probably every single combination of pharmacologic and mechanical circulatory support you can possibly imagine. And my assumption always is that that's what the patient needed or needs. I do like a warm handoff when the patients are wheeled into the ICU, usually from the cardiothoracic anesthesiologist or cardiothoracic surgeons. It gives me a little insight into what might have happened in the operating room, what the operative team was thinking, and what the anesthesiology team was thinking as they were titrating the vasoactive medications. It also helps to inform how I might expect the patient to be managed, particularly in the very early postoperative period. So what Perry Chop, again, I love that name too. What Mr. Perry Chop was on, dobutamine, epi, inhaled nitric in a balloon pump that was removed early. It's a pretty common regimen in my historical experience. Atrially pacing the patient at a rate of 100, 110 beats per minute or so, also quite common, particularly to attenuate RV dysfunction and RV failure, and ensuring adequate chronotropy while preserving, ideally, the critical AV synchrony. Obviously, the more hemodynamic support therapies a patient is on and that's employed, the sicker they tend to be and the slower I work on weaning them. I very much adhere to sort of this standard principle in the care of critically ill patients, whether it's in the cardiac ICU in the preoperative setting, the cardiothoracic surgical ICU in the postoperative setting, the MICU, it doesn't really matter. And my job is to apply as much therapy as the patient needs to achieve some reasonable homeostasis, and then I get the heck out of the way. Another way to say that is like I never try to do too much, nor do I try to get in the way of the patient trying to make himself or herself better on their own. So early after transplant surgery, I monitor serial labs, obviously very closely, looking for evidence of complications related to the postoperative or perioperative environment, like bleeding, monitoring the invasive hemodynamics. Patients after cardiac surgery and transplant patients aren't all that different. They require early resuscitation. They tend to have low cardiac filling pressures actually when they come out, generally are intravascularly volume contracted due to a lot of factors, bleeding, insensible losses. the increased urination that happens often with cardiopulmonary bypass, inflammation related to the perioperative environment with subsequent vasodilatation, the rewarming process, the effects of ongoing or pre-existing systemic acidosis. I learned a lot of things from surgeons over the years. Some of these sayings I still do. You've probably heard some of these sort of sayings from some of the old school clinicians. Tell me if you've heard this one. Fluids before midnight, Lasix after midnight. That's one. Another one said, swell to get well, pee to set free. So this idea that you're like resuscitating the patients early after the operative events and the operative insults, and they need volume resuscitation as you work to improve their volume status and attenuate the acidemia and all the other complications. And at some point, the patient's vascular tone starts to improve after they've sort of rewarmed, and you'll see their cardiac saline pressure start to rise. And then you start sort of switching from a resuscitation strategy to more decongestive strategy. And that's when you also start weaning some of those vasoactive medications. I'm one of those guys that tries not to do too much early when it comes to vasoactive medications until I'm done with the resuscitation of the patient, unless something else, some negative event compels me to do so earlier. And then again, this is not necessarily an evidence-based strategy, but this is the strategy that has worked well with me and my colleagues over the years. I start working usually on weaning the vasopressor therapies, or at least reducing the vasoactive dosages of agents that have sort of inotropic and vasopressor properties to sort of more classical inotropic levels, like the epi, for instance, at a dose of 0.05 mics per kilo per minute. I try to get that down to more normal inotropic dosages of 0.01 to 0.03 mics per kilo per minute range. And then I'll start to turn my attention towards the systematic weaning and removal of inotropic therapy. And I'm methodical about it, particularly in the transplant patient, because I've seen far too many complications with aggressive weaning. The patients look great. You could wean them off those medications in the first couple hours. You could do it. And then all of a sudden, the patients start to decompensate, and because they require some of the catecholamines or the inotropic support more than you thought that they might. So I'm very methodical about it. The inhaled pulmonary vasodilators, I've found every sort of practice in the book. Some will wean it off right away while they're still mechanically ventilated, and some will leave it on, liberate them from invasive mechanical ventilation, apply it through high flow nasal delivery, and then wean it off later. And, it's obviously also influenced by the patient's clinical history and their hemodynamic state. Again, I think as long as you're sort of methodical and serial about it and are prepared to deal with the consequences, positive and negative, right? Ultimately you're deciding to sort of wean, you choose an agent, you decide how you're going to do that. You're monitoring their hemodynamic and hemometabolic state. If they do well, great, you're high-fiving your neighbors and you continue to do that. And if they start to decompensate, decline, they start to become acidemic, their hemodynamics start to get worse. You have hopefully in your career learned to cultivate the skill set around pivoting. So you pivot. You say, okay, that didn't work. Let's stop that and let's go to something else. So that's kind of how I handle that. And then obviously if the patient has a mechanical circulatory support device in, I try to get that out as soon as I possibly can, because the longer they have those devices in, the more likely they are to develop a complication of those devices. If it's in the groin, they're not going to be able to sort of get out of bed and rehab particularly quickly. But it's all in a sort of a case-by-case basis. And then I think one thing that we have to emphasize this entire discussion is this relationship with colleagues and communication. In that setting, I'm constantly communicating with the surgical team. I'm constantly communicating with the anesthesiologist and making sure that we are all on the same page. So I think that's vitally important. We just had a conference where we invited a surgeon, and the topic we gave the surgeon is, what do you want to be called about in the middle of the night? What are the reasons that I, as a critical care cardiologist, should wake you up in the middle of the night? And I think that's important to establish sort of guardrails and ground rules about what you think is most important. What I think is most important is setting those sort of ground rules while the sun's still out is always a smart plan. Like good Boy Scouts and Girl Scouts, you're prepared.
I feel like as a cardiology fellow, we're always in the preoperative setting, and I'm in charge of the inotropes, and I get to do all of the things. And I, again, can't emphasize how important the interactions with my surgical colleagues and their preferences and how they manage their patients post-operatively impacted me during my transplant year. Dr. Kaczorowski, I was just curious, again, everybody has their stuff, but do you have preferred agents? Do you have ways that you like to go about this as somebody that's really calling the shots in the OR and then bringing them up and being in charge of that management early post-operatively?
Yeah, I think weaning off a bypass, I think we generally will start with a basic dose of epinephrine, somewhere along the lines. Epinephrine around 0.05 is generally what we'll start with. And then possibly either 5-adobutamine or dopamine. If there is RV dysfunction and if there's blood pressure for it, I'd love to try to work in some milrinone. But again, I think if the patient's hypotensive, you've got to be a little bit careful about that. If they have a high PVR, we will generally use Flolan, but either Flolan or nitric oxide, I think is great. I agree with you. I'm generally not terribly aggressive about weaning these things. I'm pretty slow on weaning. I want to see the patient get through the first couple of days safely without any RV dysfunction. If I had a patient with an RA of 18 and an index of 1.6 on 5-adopamine and 0.05 of epi, I definitely think there's a lot of things I would do, but I'd be thinking about putting that patient on VA ECMO if they're not getting better with increases in the inotropes. So I think that's where I would start. I'd have a low threshold to escalate those doses up to about 0.1 of epinephrine, 7.5 of butamine, try up to 0.25 or even 0.375 of milrinone if there's blood pressure for it. I would not really want to do that at the expense of very high doses of vasopressin or levofed. So if we're on 0.04 of vaso or 0.06 of levo, I probably would not use milrinone. And then again, if the index is low and I'm on all those things, I'll have a low threshold for mechanical support. I think you need to keep the recipients, these patients, perfused, and you can't overpress them. Otherwise, you're going to get in a situation where you have multi-system organ failure.
That's super helpful. And I think hearing both of your answers, it really highlights the art of medicine, right? There are multiple ways to skin a cat, and everyone has their different practice, and we're all working to make these patients get better quickly. Another question that's sort of off script here, but if we have a second, I'm curious to know how both of you approach lactate checks in the post-op period. How frequently, how much stock you put in it, how quickly should it clear? Just what are your kind of gut reactions?
Well, that's a loaded question too. Lactate's probably the best marker we have of perfusion, but it is a messy biological marker, right? Because it's not just influenced by tissue hypoxemia, tissue perfusion or malperfusion, but it's also influenced by a number of factors that can be perturbed in the operative setting, right? Mitochondrial dysfunction, all these vasoactive medications, in particular epi, that is a commonly used drug in the postoperative cardiac surgical setting. Epi can certainly increase lactate compared to some of the other vasoactive medications that we use. If they have end organ dysfunction, particularly hepatic dysfunction, but renal dysfunction as well, that can influence lactate. And when patients have had really normal invasive hemodynamics, reasonable cardiac outputs, I've seen these, particularly after transplant, where these lactates just keep rising. And as the lactate keeps going up, my sphincter tone gets higher and higher as well. And until finally, starts to come down, and I'm very thankful. But like Dave said, in patients that are requiring increasing dosages of vasoactive medications in whom you think the lactate is representative of their perfusion state, I have a very low threshold for at least recommending to my surgical colleague the consideration of early temporary mechanical circulatory support. It'll be interesting. This field of perfusion markers is evolving, not just in the postoperative setting, but in the preoperative cardiogenic shock setting. And there's probably going to be better biological markers to use at some point than just lactate or in combination with lactate, things like the PCO2 gap or simple things like capillary refill time in the early preoperative setting is actually a pretty reasonable perfusion marker as well. So like everything in critical care medicine, I try to take all the data, and you're bombarded constantly with data in the ICU setting. And our job is to take all that data and sort of aggregate it together to paint the picture of what's happening. I do think, especially in the early postoperative setting, frequent evaluation of the patient is prudent. I think the kinetics of lactate would suggest that probably checking it any more frequently than every 1 to 2 hours is probably not all that helpful. But I think from that point on, every 2 hours or so is probably reasonable, along with all the other data that you're collecting. And a lot of times in that setting where you're sort of worried about the patient, I'm constantly on the phone with or at the bedside with my surgeon. Sometimes we're just looking at each other and saying, is now the time to pull the trigger? Should we wait another 30 minutes? Should we wait another hour? And it's like anxious parents sometimes sit there and watch for a while.
I certainly agree with all those things. I mean, I expect the lactate to go up. I do a lot of adult cardiac surgery as well. And it's really kind of interesting because you can have some very complex adult cardiac surgery cases where you have similar durations of cardiopulmonary bypass time. You can have the heart clamp for a while, do a pretty complex operation. And I feel like you see more lactate increase in heart transplants generally than you see in those patients for whatever reason. I don't think anyone knows. It has been studied. There are papers out there about it. And generally the lactate will go up after a heart transplant. I agree. I think you have to look at other clinical parameters. If I get a call that the lactate's going up, but the index is 2.9 and the urine output was 300 last hour, I'm not sweating it at all. I know that we can give the patient a little bit of volume if the CVP can tolerate it, and they're probably going to be fine. Now, if the index is marginal and they're not making much urine, then I worry about it very much. We usually check lactates as a matter of routine every 4 hours or so in the first 24 hours after transplant. And if I'm concerned about it, if the index is low or there's something else that I'm worried about, if the CVP is high, I may get them more frequently than that. It drives our intensivists crazy. I get a lot of blood gases, but I think it's valuable so you can really get a trajectory of where the patient's heading. And if you need to institute mechanical support or take other measures.
That's super helpful. I feel like we could have a whole nother episode on just lactate, but we'll stick with the critical care theme here. And we have our next question. So we're going to throw a little bit of a wrench in Mr. Perichop's case. So on his intraoperative TEE after coming off bypass, he was noted to have a dilated RV with some depressed RV systolic function. In the ICU several hours later, another TEE is performed, which demonstrated severely dilated RV and severe systolic dysfunction. LV size was noted to be small with hyperdynamic function. There was mild to moderate tricuspid regurgitation, and his invasive hemodynamics currently demonstrate a right atrial pressure of 18, PA pressures of 33/18 with a mean PA pressure of 21, a wedge pressure of 14, and a cardiac index of 1.66 on dobutamine 5 micrograms per kilogram per minute. And he's also on epinephrine 0.05 micrograms per kilogram per minute and inhaled nitric oxide of 20 parts per million. Over the subsequent 12 hours, he develops progressive oliguric renal failure. His nitric oxide is increased to 40, his epinephrine's increased, and his atrial pacing rates increased, and he started on high-dose diuretics. Ultimately, he requires initiation of continuous renal replacement therapy and vasopressin to maintain a MAP greater than 65 for volume removal. So Dr. Katz, how commonly do you see RV dysfunction in the immediate post-heart transplant period? And would you classify this patient as having PGD now? And in general, can you just walk us through kind of PGD risk factors and just general management strategies?
Oh, man. How commonly do I see RV dysfunction by echo? Like all the time, right? But then the other question is, how often or how common is it that I see sort of clinical RV dysfunction or right heart failure? And it's not uncommon in the postoperative setting, particularly in the post-transplant setting. Fortunately, even the RV is a fickle chamber. It doesn't take a joke too well and will fail pretty quickly. It is fairly robust in that it will recover often quickly. And RV dysfunction can be transient. It doesn't necessarily always require an immediate intervention other than just sort of closer monitoring. But true RV failure can be a serious concern. Mr. Chop here definitely has evidence of progressive RV pathology by serial echo, worsening RV hemodynamics, and then subsequent cardiorenal perturbations as a result of right-sided failure and systemic venous congestion and hypertension. And he's developed that despite, as Dave was pointing out, a reasonably intense pharmacologic and pacing regimen that would help support the right heart best we can with enhanced inotropy, chronotropy, a decongestive strategy, and unloading. And the LV by echo is small, it's hyperdynamic, the left-sided filling pressures are normal or even low. And so clearly the new heart is having trouble getting blood from the right side of the heart to the left side. I oftentimes say this, that the right heart doesn't have to be great, it doesn't have to be good, but it does have to be good enough to get blood to the left heart in the early postoperative period. And so one thing that I always want to exclude in any cardiac surgical patient who has some of these features is that the patient doesn't have tamponade, because it can present a lot of times in similar ways. You see these rising right-sided filling pressures, a low cardiac index, and the patients almost abruptly stop peeing for a variety of different mechanisms. But once after you exclude tamponade, which can again mimic some of these findings, then turning your attention on how to enhance RV support is, I think, the crucial next step. And the medical team in this case starts continuous renal replacement therapy to enhance cardiac and renal decongestion while intensifying vasopressor support to improve the perfusion pressure gradient at all end organ vascular beds, including the kidney. The patient has this sort of RV predominant primary graft dysfunction. I would generally define PGD as severe ventricular dysfunction within the first 24 hours or so after transplantation in the absence of any other obvious cause like hyperacute rejection or complications or things like tamponade. And clinically, you'll see this low cardiac output and high cardiac filling pressures, and often hypotension and other markers or manifestations of systemic hypoperfusion. And we classically think of PGD as sort of isolated LV or biventricular failure, but there's also a phenotype, which is a largely isolated RV predominant. That seems to be what Peri-CHOP has, and criteria do exist for its definition and severity assessment. The pathophysiology, as I think was pointed out earlier, is likely multifactorial, related in part to ischemic injury, in part to reperfusion injury, in part to the marked inflammatory milieu that results from surgery and even brain injury during cardiopulmonary bypass support, in part, and I emphasize this on the medical side, in part related to how sick we send patients to the operating room, because the sicker they go in, the sicker they come out, and the more likely they are to have some graft dysfunction. If they needed preoperative mechanical circulatory support, that is a risk factor. If they are on some concomitant medications, which I think Jenna mentioned, perhaps that can impact it. The presence of subclinical infection and many other things can potentially lead to an enhanced risk for PGD. But the goal is to identify. You want to know if your patient's doing that. You want to know it early so you can institute management practices and strategies early. For Mr. Chop's case, some would have probably placed an early right-sided temporary MCS device, either for the right side exclusively or something like ECMO to support the heart. And fortunately for him, it sounds like he responded to renal replacement therapy and intensive decongestion and a little bit of extra vasoactive support. And that was enough for him to buy him time so that he could start to recover. You also want to obviously ensure that you have reasonable pulmonary support, in particular that you're managing oxygenation and ventilatory requirements appropriately too, which can obviously influence RV function, particularly at the susceptible stage in the early post-operative period. So that's sort of all my thoughts. I'm curious if Dave has any other thoughts as well.
No, I think that was a really good summary. Thanks for that. I think it's a big problem. Almost all the recipients that we transplant have some degree of pulmonary hypertension. Most donor hearts are naive to pulmonary hypertension. And so when you transplant them, there's generally some obligatory dysfunction of the right ventricle, and it's variable. I think, again, by making good decisions about donor selection, you can avoid some of it, but it's always a problem to some extent. As you pointed out, if you just look at the hemodynamics, it's essentially looks identical to tamponade: high right atrial pressure, low cardiac index. And that can be really tough to deal with in the very early perioperative period. And if there is RV dysfunction, I think you want to go through the steps you outlined. You want to optimize the inotropic support. You want to optimize the metabolic status of the patient, optimize the respiratory status of the patient, optimize the volume status of the patient. But if it's tamponade, you have to get them back to the operating room and evacuate the clot or blood or whatever is causing the tamponade. So it's important to sort that out. And I think TE can be useful for that. Again, if it is RV dysfunction that's refractory to medical management, then I think you're looking at mechanical support. I still prefer ECMO as a first-line therapy. Right-sided devices that are available now are useful as well. I just think VA ECMO works so well in these patients. It just seems like they respond to it very well. So it's still, I think, my first line unless there's a contraindication. If the chest is already closed and they've got very small femoral vessels or don't have femoral access, they have peripheral vascular disease, or for whatever reason, the peripheral cannulation is unsafe, I think that's a good time to consider an isolated right ventricular support device. But in the absence of those situations, I think VA ECMO is a good way to go. The chest is still open. I'll utilize central VA ECMO. Again, if it's already been closed and there's no other indication to open it, generally we'll try to use a peripheral strategy.
Thank you so much. That was really helpful. So for our patient, fortunately, he does not require any mechanical support, and his hemodynamics gradually improve. He comes off CRRT, so his RV is doing much better. And we've already discussed this a little bit nicely. So just in the theme of hemodynamics postoperatively, he gets a TTE on post-op day 7 and is found to have a large 4 by 8 centimeter hypoechoic pericardial effusion along the RV border that extends to the LV apex with fibrinous material. There's no sign of chamber collapse on echo, and on post-op day 11, he ultimately gets a subxiphoid window with 300 of serous fluid drainage, and a large anterior dead space was encountered. There was no clot, no evidence of bleeding or exudative material. Dr. Kaczorowski, as you can imagine, this is going to be a question for you. So pericardial effusions post-heart transplant and just in cardiac surgery in general can be really common and have a few different etiologies. Can you just walk us through how you think about early development of pericardial effusion post-heart transplant indications, as you kind of alluded to, for taking them back to the operating room and strategies for windows.
Yeah, absolutely. As you put it out, pericardial collections are not terribly uncommon after heart transplant. In many instances, there's a lot of space in the chest. In many instances, the donor heart is much smaller than the recipient's original heart. There may have been an LVAD, there may have been abnormal anatomy. And whenever there's space, that space is generally going to be filled with fluid. Coming into the transplant, the recipient may be anticoagulated. They may have had prior sternotomies. Again, they may have had an LVAD, all of which requires a fair amount of dissection. When the heart transplant's been done, there's a lot of suture line in there. There are cannulation sites, pacing wire sites, all of these things can potentially bleed. And so in the early perioperative period, in the first couple of days, generally, if there's a pericardial collection, it's going to be the result of early perioperative bleeding, many times from a surgical site, from an anastomosis, from sternal wires, or something along those lines. And if there is any sort of right ventricular compression, if there's hemodynamic instability, it's certainly a good idea to drain that collection. And depending on how significant it is and what the location is, it may influence the approach. If it's not complex, there's not a lot of clot or septations, a subxiphoid window may be adequate. Sometimes these things can be drained through a left mini thoracotomy. If there's a lot of clot and you're worried about ongoing bleeding, then reopening the sternotomy may be advisable. If you get out beyond those first several days, there can be other etiologies for pericardial collections as well. Certainly there can be late bleeding, but that becomes less and less common as time goes on. There can be other reasons for bleeding. So if perhaps the patient has temporary epicardial pacing wires and these were removed, that may result in bleeding. At our center, we generally cut them to avoid that, but obviously you're leaving some material there if you do that. If a patient undergoes a biopsy, the RV can become perforated. I have seen endocardial biopsies with fat, and there's really only one way that happens, which is you're basically taking a full thickness biopsy. I've seen injuries from central line placement that comes later. So all those things can result in bleeding. If you're talking about later time points as well, you can also just have inflammatory serous pericardial collections. And again, in any case, if the patient's hemodynamically unstable, or there's any evidence of compression of the chambers, particularly the RA or RV, or very high filling pressures, it's probably advisable to drain these collections. I would say in addition to that, if the collection is rapidly accumulating, like you have an echo one day and there's nothing or very little, and then there's a substantial amount there the next day, probably advisable to think about draining that collection as well.
That was beautiful. Quite the masterclass of pericardial effusion. So thank you. I think a memorable phrase there was, where there's space, that space will be filled with fluid. Oh, I like that. Okay, now we're going to take a step sideways in Mr. Perry Chop's case. No post-operative transplant discussions complete without talking about immunosuppression. So this next sort of prompt is for Dr. Katz. So as a reminder, Mr. Perry Chop is our 65-year-old Caucasian male who had ischemic cardiomyopathy. He went into transplant on milrinone and a balloon pump. He was not sensitized, CPRA of 0, and he had some degree of chronic kidney disease with a GFR in the low 50s prior to transplant. He received induction therapy with basiliximab, 20 milligrams given in the OR and a second dose on post-op day 4. We know that there are, lots of options for immunosuppression post-transplant, different induction agents that can be used, and centers greatly vary in their practices, and it really comes down to patient selection. And lots of factors, degree of sensitization, cross-match, many things to consider. So, Dr. Katz, considering all those things, can you walk us through how you think about indications for induction therapy post-transplant and long-term outcomes? And if you have any thoughts on different induction agents, TG, basiliximab. And then lastly, if you do use induction therapy, does that change how you think about long-term maintenance immunosuppression?
Another good question. I suspect you could get multiple heart transplant doctors in the same room and they all have a different answer, perhaps. I suspect if I asked you guys, Natalie and Jenna and Shazli, you may have different answers than me. So first, baseline acknowledgement, I am not an immunologist. This is an area, however, that I've learned a ton about and continue to learn. Like, it's always been impressed upon me during my career to be a lifelong learner. And this particular aspect of advanced heart failure transplant cardiology is an area where I'm constantly learning, and we're really privileged where I'm at right now to have some real experts, cutting edge experts, clinical investigators and clinical trialists in this sort of immunosuppression space. So I'm hopeful that the fruits of their labor will help inform us over the years in the near future. And I think that the contemporary data would suggest that induction therapy is probably used in about half of patients who undergo heart transplantation. I feel like it's more than that. Like just anecdotally, I feel like it's the rare patient that's actually coming out and we're not giving induction therapy to, but that may be a completely biased observation on my part. I'm curious to what you all think.
It's rare that we use it. So,
Is that right? Oh,
yeah.
see, this is what I'm saying.
Yeah.
Yeah, the practice is quite
It was
heterogeneous and it's
fascinating.
very,
I was used to doing steroid only, and that was really all we
yeah,
did. So,
yep, very good. We're very aggressive about the immunosuppression in our patients at the institution where I currently practice, and we hate the immune system here. We beat it to a pulp if we can. Obviously, we use it in the sensitized patients. Mr. Perry Chop wasn't particularly sensitized at all. In fact, I think his Perry was 0, if I recall. We do use it and consider it in patients, obviously, that have some baseline renal dysfunction, which he had, and particularly in whom we think that there's going to be a delay in the initiation of calcineurin inhibitor therapy because of the potential of kidney dysfunction delaying its initiation. The overall goal, obviously, is to achieve some high intensity immunosuppression early in the post-operative period to reduce the risk of rejection. And as also mentioned, any delays in nephrotoxic calcineurin inhibition initiation. Again, I think as we've already just pointed out in this discussion, I think institutions have their own practices and their own cultures. And I found it very different at different places that I've been, for sure, particularly when it comes to considering induction therapies. Most places have standardized protocols and protocols are good. They provide some homogeneity into the care that we apply to our patients. So some will use it particularly in multiparous women or patients in whom we're doing a bad explant and transplant, younger patients who have more robust immune systems. And these protocols often are specific to the type of therapies that are used. And you ask about the difference. I mean, there are observational and small series that suggest there are perhaps better efficacy and reduced antibody production with anti-thymocyte compared to basiliximab, but there are no really robust head-to-head prospective data or long-term outcome data that I'm aware of at this point. And again, the use of these therapies obviously have to be balanced with the risk of, in particular, early infection risks. I'm not aware of, I don't believe there's any sort of true consensus regarding the use, dose, or duration of induction agents in the heart transplant recipients. If you're a glass half empty kind of person, you're like, oh man, there's just nothing to guide there. If you're a glass half full person who's scientifically curious, and it's a really great opportunity to move the needle with a collaborative scientific investigation moving forward.
Sternal complications are most commonly seen in the first 30 days after transplant. Usually I'd say after day 7, but before day 30. It is possible to have late sternal complications. You may have sternal non-union that only presents later, and it can be weeks or months later. A patient may notice some clicking or some instability, and that may be bothersome to them. Every once in a while, and this is also uncommon, but every once in a while, you'll have a patient present late with an infection, and perhaps one sternal wire will be infected and require a removal. Generally, I think transplant patients are very high risk for sternal complications. A lot of them have had prior sternotomies. They may have been very ill prior to transplant. They may have poor nutrition. They may have been hospitalized for some period of time. And then, of course, they're immunosuppressed, as we were just discussing. Many of them are on steroids, mycophenolate, other things that may inhibit healing. So there is some risk for sternal wound complications in these patients. Optimizing their nutrition ahead of time is something that can be done even prior to the operation. Really being very careful in the operating room, really trying to get a very midline sternotomy, being very meticulous with the closure. Those are things that can be done to help prevent sternal complications. And then post-operatively, we don't want them pushing or using their arms very much. We'll ask our patients to avoid any heavy lifting greater than 10 pounds or so for about 4 weeks after the operation. We generally ask them not to drive for that period as well. We see them back in the clinic and make sure that the sternum is well healed and then clear them to begin doing those things.
That was fantastic. Thank you so much for that. It's really nice to see our patient finally going home and asking those questions. So I guess I have the task of wrapping this up. So thank you all for a fantastic case. We've covered a lot of topics today, the basics of donor selection, DCD, DBD, immediate hemodynamics in the periop period, induction therapy, and then homegoing recommendations. I think there are just too many pearls to tell you in 30 seconds. So I'm just going to leave it with my 2 favorite things that each of our experts said. So my favorite thing that Dr. Kaczorowski said was expect some obligatory RV failure. And then Dr. Katz, you said a couple funny things, but we'll go with we hate the immune system. So thank you guys so much.
That's so wonderful. Okay, I do have one final question for each of you. We ask it at the end of each of our CardioNerds episodes. But what about transplant makes your heart flutter? What are the things that you're really excited about for the future? Because as Dr. Katz pointed out, it's great to be glass half full, and there's so many wonderful things in our field that we get to enjoy and be excited about. So I'm curious about yours.
Yeah, I agree. There's so much excitement. It is a really fascinating, rapidly evolving field. I am particularly curious to see how we continue to expand the donor pool and match organs to recipients through novel strategies. I'm interested to see how DCD continues to sort of broaden and explode. I'm interested to see how the different procurement methodologies and the transportation of these organs changes and evolves. I am curious to see what happens with the allocation system and if that evolves, which I expect it will over time, and how that ultimately influences our waitlist times, our matching of patients based on illness severity, and ultimately our transplantation rates and outcomes. So a lot to be excited about. The other thing I love about transplantation, it is a team sport like no other team sport. And I get a kick out of that. I like working with all different types of people, particularly my cardiac surgeons. And so I'm thankful for transplantation because it allows me to sort of fortify that relationship.
Well, I have to agree with all those. I think it is definitely a team sport. I think that's a lot of the fun of it. Obviously, we get to take care of some very sick patients and really, truly make a difference in their lives. I think some of the things you highlighted are really exciting. I think expanding the donor population by using TCD donors, utilizing these novel strategies to preserve organs and take them further is really, really exciting. I also hope we see some innovation in immunosuppression. I think we still have a lot of work to do there. And then I hope we can expand the number of organs available for our patients even further through other means, including xeno. So I think there are a lot of really exciting things happening out there, and really can't wait to see how things play out over the next number of years.
Thank you. It was a lot of fun.
Thanks so much.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marques. I am an intern in the CardioNerds Academy House Thomas, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.